So we're going to move into a section where we're actually going to demonstrate using the guide. And I'm really lucky because Beth Brennan volunteered to be the clinician, and she hasn't actually used the guide. And so she's going to be modeling it sort of for the first time, and Jen is going to be our patient. And let me tell you a little bit about Jen and who she is. But she's not her usual self here. She's a 54-year-old, very intense investment banker, and she has twins that are in high school, and she unfortunately has lung cancer. And she's failed the first 2 lines of chemotherapy. She's on her 3rd line. She's having some more dyspnea and fatigue. She's been admitted twice in the past 6 months for dyspnea. And today, Dr. Brennan will say is her oncologist, and she's talking with her about using the serious illness guide. And no, I think that's good. And I think Beth is going to do a little bit of an introduction to why she's having the conversation. And any questions before we start?
Hi, Jen. It's good to see you today. Hi. How are you doing? How are you feeling today?
Not so good.
Not so good? I'm sorry. How's your breathing?
It's about the same.
Yeah. Okay. I wanted to bring you in today and talk a little bit about some hard things to talk about. I think we have a little bit of a pause, and I wanted you and I to talk a little bit about what your goals are. I want you to know that I'm talking about this not because I have an agenda, not because I want to tell you that I want you to do X, Y, or Z, but because I want an opportunity for you to tell me what's important to you and what you're thinking about, and I want to know as we go forward, and I think we have a pause right now to maybe have that conversation. What do you think?
Okay.
Okay.
I want us to move forward because this thing is
Okay. It'd be easier if we had the rollies in the office, but okay.
Okay. Yeah, I'm game.
Okay, good. I'm glad, because I know that this can be a difficult conversation, but I really want to give you an opportunity to tell me what's going on, okay? Let me start by just asking you, what do you understand about where you are right now and what we've done and what your disease is like?
Well, I mean, I think I'm just going to beat this thing. That's probably the most important to me. I know that the last 2 rounds didn't go well. I think, do people know I have lung cancer? Okay. So, yeah, I just am very clear that I have to beat this. And I'm the kind of person who, when I set my mind to something, I get it done. And yeah, I think that's probably the most important thing for you to know.
Okay. So you're very focused on the treatments and getting things to work and
Yeah.
being here as long as you can be.
Exactly right. My kids are incredibly important to me, my husband, of course, and I just have to beat it. That's really, really, really been my focus.
Okay. So I want to be there and support you for that focus.
Thank
okay?
you. I appreciate that.
I also want us to talk, if we can, and maybe we don't do it all today, and maybe we can't talk about it today.
Okay.
But if you feel like we could, I'd like us to talk a little bit about what would happen if we can't accomplish that.
Okay. So I think, my what's been on the top of my energy and my attention has been, as I've already said, is beating this. But I guess I haven't really looked at that other option of not making it.
Yeah.
So I don't really know how to do that.
Okay. I want to share with you that I do have some concerns about how the treatment's going. and about how your disease is progressing. And although I want to maintain that hope, and I'm going to keep trying with you to do that top goal, I want us to talk a little bit about what happens if it isn't going to be as long as we'd hoped.
Okay.
My concern is that I'm worried that we may be coming to a change in your disease, and that it may be less time than we'd hoped for.
Okay. You know, as I'm thinking about it, I guess, given that things didn't go so well in the first 2 rounds, I guess that makes sense. I just haven't allowed myself actually to look at that option. And yeah.
Can I ask you what are your biggest fears if that happens? And we don't have to say that it is happening, but
Okay.
if it does, what are your biggest fears around what might happen during that time, or what it might look like?
I think being a burden to my husband. I think I mean, to be honest, it's really hard for me to go into this space, but the first thing that comes up is, how will he handle this? We haven't really talked,
Yeah.
and certainly with my kids, I haven't gone there at all. They have enough on their plates.
Yeah. Do you think they might be thinking about it already, though?
You know, I guess so. I hadn't. I think I've been so focused on beating this thing that I just haven't allowed myself to even explore it. So they're smart kids. You're probably right. I hadn't. You know, maybe they're worried.
In my experience, it's a relief for family members to be able to talk about this, and for them to hear from you about what's important to you and what you'd like from them and what you'd like for them around this time. So maybe that's something I can help you with. Maybe it's something that we can all have a conversation about together and let them ask questions. Or would it be okay with you if they asked me questions, if you didn't feel comfortable?
You know, I hadn't gone here at all or gone to this idea, but I think maybe first with my husband, because we haven't talked at all.
At all with
and
the kid, yeah.
But that might be good here in the setting with you, and then
Yeah.
maybe bring them in.
Okay, so maybe we can bring your husband in at a future time, and we can talk about that. And maybe it'll give us some more time and you some time to think about what's really important for you about this time. What are the things that you really want to do, or the things that you want to avoid? Have you thought about that at all?
Well, I'm just realizing that I didn't want to think about the possibility because somehow I thought that would make it happen. So this is a whole new framework, actually.
Yeah.
Because I thought if I didn't make it, then that would make me not make it. So this is new territory for me.
Okay. I want to tell you that there, in my experience, and in some of the evidence, talking about this actually doesn't shorten your life. What we know now is that sometimes it lengthens it and makes it better. So I'm glad that you're able to sit with me today and talk about it a little bit, because I think there's some real benefits to you and to the people that you shared with me that you're worried about today.
You know, I have to say I have a kind of relief that I didn't anticipate. This feels important.
Okay.
Yeah.
Good.
Thank you.
Okay. I have a little cheat sheet here, and if it's okay, I'm just going to look at it because I want to make sure I talked about the things that I wanted to talk about today.
That's okay.
But I also want to let you know that this conversation's ongoing, right? So you'll go home and you'll think about it, and maybe I'll have some questions for you, or you'll think about some things, and I want you to feel free to bring it up, and we'll make some more time to do it, okay?
That sounds good.
It's
Yeah.
important.
Okay.
One thing I wanted to ask you to think about, because I think you've been very clear with me about what you wanted to do for the time being, is what kind of things do you need to be present in your life to make you continue to want to pursue this chemotherapy or perhaps something else that might cause you some discomfort? What kinds of things do you need to have present for yourself?
I think my mind is probably the most important thing.
Okay.
Yeah.
Mm-hmm.
And I think being able to eat and drink, that kind of thing, feels really basic to me.
Okay.
I think I don't want to say that if that's not there, I don't want to keep on going, but that's a little bit my edge.
But it's important to you.
Yeah.
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 That's a good thing for me to know,
Mm-hmm.
and a good thing, I think, to share with your family, too.
Okay.
Okay, good. Okay. What I'm hearing is that, and I've known you, Jen, so I know that, you have very strong opinions, and I want to support that, and I'm here to follow your path.
Okay, that's
But
good.
I'm really glad you were able to share some of these things with me today and your concerns. And I hear you're worried about your husband. And so let's try to make a time so that we can bring him in and talk about this with him and let him ask some questions. And I'm here for your children too, when that, we can talk about how we can help your children when that seems like that needs to happen, okay?
That means a lot.
Okay, good.
Yeah. And I'm a planner, so I think if we can use that as a sort of foundation or structure for what we do, that would, I think, give me some peace or
Okay.
comfort, or I don't know.
Yeah,
I don't like
think
those
it would
words.
too.
Yeah.
Yeah, no, I hear you. Okay, good. Is there anything else that
No,
that
this
I
is-
didn't bring up today that you wanted to bring up?
I just think helping me figure out how to have this conversation with my husband would be really helpful, because I don't know how to do it.
Okay, all right, good. Let's bring him in and we'll do that together, okay?
Okay, thank you. Okay.
All right. So okay. Oh,
It's here. This is a ribbon. Great.
Up here for just a sec. So Beth, how did it go for you?
Even though, it's not a real situation,
Yeah.
it always, these conversations always tear at my heartstrings.
Yeah.
And it's hard. It's
Yeah.
it's hard, and it's
Yeah.
not even real here.
Yeah. Right. Right. So it was hard, and I think that's a really honest. First, it's hard to do it in front of an audience, but I think, I really felt like you were really there with her, and you were really. And Jen is a very good actress too. We certainly were watching an expert here. But what did you do well?
I tried to ask the open-ended questions, and something I've learned is the pauses. And Jen was really good at leading
Yep.
where it needed to go, and I think
Yep.
the pauses are just so important to be
Yep.
able to be present
Mm-hmm.
and
Yep.
not have your own agenda, and that's very hard to leave at the door as a
Right.
clinician.
Right.
So that's sort of a
Absolutely.
constant struggle and balance.
Yes, and I think there were points where you were really, gave, there was a little bit of silence, and that was good. What else did you do well? Because there were so many things.
Well, there was one thing that I don't know if I did it well or not well, but
Okay.
it's sort of in my
Yeah,
brain.
yeah.
And that's, and I started out with, it's difficult to have the conversation, but how much of yourself to bring into the conversation? Like, sharing that it's difficult for you, but that it's
Yeah.
hard for me too.
Yep. Yep.
And how much of that do you bring in without having the patient start taking care of you?
Yes, right, exactly.
Yeah, so that
I think
dynamic.
that is a delicate balance for sure, because I think showing some humanity is really a way that we connect with our patients, but we don't want to she's already worried about burdening her family, and she doesn't want to burden our doctor. And we certainly saw this in our trial, where, you know, patients wouldn't talk to their oncologist because they didn't want to disappoint them, you know, that they were scared, or, you know, and that's one reason why it can be helpful to have a palliative care or someone outside of the relationship where they feel safe to talk about things. Were there any parts where you felt, I know you said you felt like it was hard, but where you particularly felt like you were struggling or worried?
I was worried about pushing you too hard, because you know, you were so clear about I am focused on this, and so I was worried about how far to push that without losing you. So how to kind of gently push her forward, but not lose her. Yeah, I think that is a delicate balance. And she was so focused, right, on like, I'm going to beat this. I'm going to, you know, I can't even go there because it might then be real. Jen, do you have anything to add?
No, I mean, I'm not that person, but it felt, I mean, so I had a script with who this person was and what was important to her and how she was, and it really felt, so this is my second time I got to be this person yesterday, and she's very real to me.
Yeah,
and I know this person. Actually, I have a dear friend who is in this place, and she has not wanted to look at it. So it actually was easy for me to go there.
Right. And one of the things that I think Beth was able to do in this conversation was kind of appeal to Jen's planning nature, right? So she didn't try to like hit her like and say like, oh, you know, we're not going to beat this thing. She aligned with her. She said, I'm with you on this. I stand by you in this. And I also think that we need to do some planning together. And so I think that was a nice way to sort of hold both at the same time, sort of this intense will to live for her kids and not be a burden, and also sort of look at the reality of the situation. And that's, I think, one of the harder skills that we have in palliative care and having these conversations is to sort of develop that muscle to do that. So, all right, I'll let you guys off the hook. Do you have anything else you want to share about? No?
I really do like your guide.
Oh.
And being able to reference it and make sure
That's great.
And I just say one thing that there was, even though I know I was acting, but there was a relief. I could really feel the relief of, okay, someone is going to help me have this conversation. I think even though in my mind I didn't want my family to know and there was, okay, I need to do this. Now the truth, it's like truth or something.
Yeah, absolutely. Okay, great. And I'm going to open it up to the audience in a minute. So I'm going to go through the guide, and I'm going to go through the guide and talk about how Beth used it at the same time, I think. We'll see how this goes. Okay, so you can pull out your guides. Maybe before that, let's just take a minute. What did that conversation feel like to people? Like any sort of thoughts or,
I just thought it was an excellent example of reflecting back. You know, every time that she said it, she did the reflection back and restating, and so I'm understanding. It was just a classic, really well done.
Really beautiful communication skills of I'm hearing, I think what you're saying. So listening to the person and then sort of reflecting back. Great observation. Other, yep.
Noticed no one used the word death or dying.
Interesting,
and, Yeah, and that whole conversation happened without those trigger words.
Right. So no use of the word death and dying. What do people think about that? Yeah, I think it can be okay. You know, for Jen, she probably would be out the door, right? So this kind of patient, I felt like the way that I was trained, and when I was a more younger, less experienced clinician, I would try to say, you know, oh, your prognosis is bad and you're dying, and that's someone that fires you, right? She's like that kind of person that will fire you if you say those things. So trying to figure out a more gentle way and sort of in the back door, I think is more useful for a patient like this.
Yeah, I just wanted to mention, it was a beautiful dance of intimacy. with starting out with the normal, I'm concerned, and then moving to care. There's also really lovely move that sometimes your values as a physician may not match the patient's, but there was a talk of working together and then the partnership piece. And I think once you're on that partner side, on the same side, and once that's really established, you can then start suggesting some things that might be outside of the other person's comfort zone. That was done really beautifully.
Yep. And so Beth said, I'm worried that we might not have as much time as we hoped. I'm concerned. So using that language, I'm worried, I'm concerned, to align with the patient, to sort of give that bad news in a somewhat gentle way was really done beautifully. Yep.
I really appreciated when it came to talking to the kids and to the family, and you were saying, I don't know if it was that you didn't want to burden them or what it was, but when the doctor was able to say, well, do you think they might already be thinking about it? And then also to be able to, she had a really nice phrase, to let them know what you want from them and for them. And I wondered if that was a big part of that relief that you felt, because there's that underlying awareness that's already there that you're not wanting to realize. I just thought that was done really well.
No, I think it was perfect. That was great. Yeah. Okay. All right.
I felt what happened there was really good. I'm just thinking in my role as an inpatient palliative care, the one-offness of it is very difficult because I don't get to have necessarily that relationship to begin with or the relationship to follow through. And so what I thought was really great about that was that you had the freedom, as you do with as a primary care physician, to allow for that, to have some trust that there's going to be something happening in between, and you'll get back again. And so as I'm looking at this, I'm just trying to figure out, well, how do I do this within the context of a one-off?
Yeah, I think it's really challenging, and I think you bring up a really good point. I think, there's some trade-offs in doing inpatient palliative care, right? So you have a unique opportunity. I think it's really important. I generally try to not have this conversation the first time I'm meeting someone. I really try to get to know them first. Or if you're going to have it, then I might not give a prognostic disclosure. But I think that getting to know someone first before trying to jump into this, sometimes you don't have that luxury though in palliative care, and you have to establish a rapport really quickly, and it can be challenging. I also think though sometimes in inpatient palliative care, we're able to, because you're an outside person, you have a little bit of freedom to align with those person's goals, and to, and I think that's really the key, and that's something that we saw Beth model really nicely, aligning with the goals and doing some practical planning. So she never said anything that I'm not with you to beat this thing. She never she was always on the same page as her, and so I think that's one way to do it, is to align with the goals and then try to bring, at the same time, some practical planning in. Other comments? Yeah, and maybe the last one, and then we'll go on to looking at the guide.
I just want to add from the nursing perspective, it's important that all the physicians that a patient sees, particularly in the hospital, are kind of on the same page. And though I understand having this whole big conversation may not be important, if you're hearing from your oncologist that we're going to beat this thing, and then palliative care comes in and says, well, just in case.
That's really fantastic
what
point.
I heard so often doing inpatient
I feel like as an
oncology
inpatient
nursing.
palliative care provider, half of my job is really working with, maybe more than that, with the other clinicians, and trying to come up with Janet Abram is one of my mentors. I don't know if anyone's ever had an opportunity to work with her, but she is the most amazing. She's an oncologist, and she'll sort of sit in a family meeting with an oncologist and innocently ask, well, so what do you expect? How long, what is this patient's prognosis? Or, sort of prompt them to, or talk outside the room first and come up with what is our plan for this family meeting? What are we going to communicate? What is the goal? So I think that's another big part of what we do in the inpatient setting. So let's go ahead and look at the guide. And Beth followed the guide and also made a few adaptations when she was working at it. And we're going to go through it sort of question by question and how it works. The first part, I think, is incredibly important, the setup piece. So I'd like to take a step back and talk together about where we are with your illness and where it's going. I like to do this with all my patients. So that piece, like sort of normalizing it, can really, all these things about the setup are to reduce anxiety about having the conversation. Then you ask permission, is this okay? So that allows people, the ability to refuse, and people will refuse, but what we do with those patients is to say, oh, that's okay, but we still are gonna need to do it in the future. So you don't sort of let them off the hook. And then you need to also offer a rationale. The goal is to make sure that I have all the information about what matters to you most so that I can provide you with the care that I want and so that I can best support your family if they ever have to make decisions for you. So you have to give them a reason or a hook about why you're doing it, because it's not an easy conversation. And most people don't want to burden their families, so to bring that in can really allow people to enter into the conversation. The other thing that I think can sometimes be helpful is to say, we're not going to necessarily, we're having this, sometimes if you bring up this, they're like, well, why are you doing this today? You have to reassure people we're doing it today, because you're doing well, and there's no crisis right now. And that also allows you to say, we don't have to make a decision today. If you're in that setting where there's not a crisis and you don't have to make decisions, that can also really reduce the anxiety. And also to say that you're not necessarily going to be changing their treatment plan. You're just going to be talking about things. And I think Beth actually said that. We're just going to be talking about this, but we're not planning on changing anything. So then the first question is, what is your understanding now of where your illness is? And I think this is a really important, because I've been part of so many family meetings where they go through this whole thing and the family actually has already decided. You get to the end and the family's actually already decided on hospice, and you spent 40 minutes going through this. And if you had started with, what's your understanding? And they say, well, I understand that it's not getting better and we were sort of curious about hospice. You're in a totally different place, right? And it's more efficient, it's more efficient to do this. So that's a big one. How much information from me would you like about what's likely to be ahead? So that's really a permission question to give a prognosis. So some people will say, one thing that's important to note is that about 90% of people want to know their prognosis, okay, including about time. So, and what I see people struggle the most with is in giving that prognosis. And Beth was really nuanced with this. She said, it might not be, I'm worried that it might not be the time that we've hoped. And I think that was enough for Jen to sort of absorb that we might be talking about a short amount of time. But I think one of the things that is important about giving prognosis is, what I watch clinicians do is they get so nervous about giving any sort of time, is that they start shifting in their seat and moving around and dancing around the issue, and that actually makes people more anxious. So if you're gonna do it, if you ask someone how much you wanna know from me and they say, well, I really wanna know everything, then you just have to say it, okay? You have to say it, and I generally encourage people to use ranges to acknowledge the uncertainty, and we'll go through this, but to use things like, months to a year, something like that. Okay, so prognosis, time expressed as a range. I wish it were different, so that's the alignment piece. I wish it were different. Yep.
I just had a question because I had a patient yesterday. If a
Uh-huh.
patient says to you,
Come on, please.
I'm loud. If a patient says to you, she doesn't want to know her
Yeah.
prognosis.
Yes, then
How-
you should not give it to them.
But do you continue in this line of conversation at all? Just saying, you don't, or you don't want to know how much time, but we should make plans, or do
Yeah.
you back off totally?
Well, it depends. So if someone says they don't want to know their prognosis, then you do need someone to talk with about what their plans are. So you have to figure out who's going to be making decisions for them if they don't want to know there. So that's, I think, step number one. And then I think you can still have this conversation. What are your most important goals given your health situation now? Instead of using if time were short, you can say, given your health situation now, what would you like to? So I think you can still do it. This was actually a big debate between Atul and I, like several years back, because I wanted to have a different guide if people didn't want to talk about their prognosis, and he was like, no, it's too complicated. It's never going to work. You got it. And I was like, well, I don't know if it's going to work if people don't know their prognosis. What's the use of this? And what we've actually been able to see in our data is a lot of our oncologists didn't give their prognosis, and they still had good results of the. So I was wrong. So I think it's a great question, though.
I find as a primary care physician, obviously the oncologists often don't communicate the prognosis in their notes, and they rarely, if ever, call us, and they rarely tell the patient what the prognosis is. So then I have to go and look at the up-to-date, and they did this treatment, and I don't know with the recent laser therapy on cutting out 5 brain mets, and then going on chemo,
what should you do?
How do we know the prognosis? How can we help assess this? Because they aren't having the conversations in the specialty care centers.
Yeah, I think this is really challenging. And one of the other problems is that even if they are having the conversation, sometimes the patient doesn't hear it, so you don't actually know. So I think we could do a better job with our systems to make it easier for PCPs and oncologists to actually communicate. I think that would be one really key way to make this better. In the absence of that, I think we're stuck kind of, looking at up to date. And I think it's important for you to have a sense so that you can help prepare people. And then I think the other thing that prognosis is a sort of a pet topic of mine that I think is really important and is sort of underappreciated. So I really try to encourage people to sort of flex their prognostic muscle. So meaning like make a guess, to yourself and then keep track of it, and see like how good am I at this or not good at, because it'll give you confidence. The other thing that I think, there's a group at UCSF that are colleagues of mine that I used to work with that came up with this website called www.eprognosis.org. And it has all these prognostic tools that can help you actually objectively come up with prognoses. And it mostly has to do with functional status. It also includes things like creatinine and albumin and things like that. But you can use it. It's free to use. And you just put in, it's dependent on patient age and where they live. So they can either be at home or in a nursing home or in the inpatient setting. And you can put these characteristics in and then get the prognosis yourself. So it's one way, but I think the communication with the oncologist is key, and I don't think we have a very good systems to encourage that for people to be able to do that, unfortunately. So that's what I'd like to see is system change to make it easier for us to do that kind of work. Okay, so you can express prognosis as a range of time. You can also express prognosis as a function of uncertainty. So although you could have a lot of time, it's also possible, and this is common for patients with heart failure or cardiac diseases, it's also possible that something can happen suddenly. It would be helpful to know what you would want if you became sick very quickly and we weren't sure if we could help you get better. And then we can also express prognosis as a function of how someone's functioning. So I wish it were different, but I worry that this might be as strong as you feel. I'm worried that in the future you might not be able to manage as well as you can now, and it's important we plan for future changes. So I think depending on the situation, you can use one of these terms, but as you practice today, I would really encourage you to try giving a prognosis if you haven't done it before, including for the nurses. Because I think one of the things that I see is that nurses get really frustrated with physicians for not giving prognosis, and then they try to do it themselves, and they're like, oh, this really sucks, it's hard, and it gives you a lot more sort of sympathy for your colleagues. And I think nurses actually do, I work with a group of nurses in primary care that actually do a lot of functional prognostic disclosure and work on what I would call cultivation of prognostic awareness. So I think nurses do a lot of that work. Once you give prognosis, you can, I think Beth talked about those pauses or silent moments, and you should really expect emotion. And I think one of the things that was hard, we have a fair number of people at Dana-Farber who are really like research focused, they're in their lab, and they're really not comfortable with emotion. And so the one thing that you can teach people to do fairly easily is to name it, or at least acknowledge it. So this seems surprising news to you. You seem really upset, tell me more. So the sort of construct here is to name what you're seeing. You seem sad, you seem upset. This is hard to hear. And then to ask for more information. So tell me more about what you're thinking, tell me more about what you're expecting to hear, or tell me more about what you're feeling. And I was even able to teach the most very intense sort of research type oncologists to do this. It wasn't easy, but they did it. And there's the other thing about the guide is there is a particular structure and flow to it. So the reason we ask about goals right after a prognosis is because hearing prognosis can be very difficult, and asking someone about what their goals are can really help them focus and feel more positive. So there is a structure of why this question is in this place. What are the biggest fears and worries about the future with your illness or with your health? What gives you strength as you think about the future with your illness? Now, some people felt uncomfortable about that this question can often bring up spirituality or religion. It doesn't, it just means that you need to support that that's someone's coping style. It sounds like religion or your faith is very important to you. And I think that's all, if that's as far as you can go, I think that's fine. It's useful for you to know. We saw Beth rephrase this in a really lovely way. Sometimes people get stuck when they're rephrasing it, so I would encourage if you're to just try the words that are there. So what abilities are so critical to your life that you can't imagine living without them? And to try it like 3 or 4 times before you rephrase it, because what happens is that when you try to rephrase it in the moment, you often get stuck and then it sort of derails you. This question, how much are you willing to go through for the possibility of gaining more time? I had the oncologists fight me tooth and nail about this question. They hated it. They didn't want to ask it. They just really didn't like it. And one of the oncologists that was most negative about it started using it. She was like, all right, I'll use it. And she used it, and then she eventually changed it to what are you willing to put up with? And she later told me, I never really thought this was a very good question, but then I started using it, and I found it's been one of the most important questions that I've had in being able to stop chemotherapy. So it can be a really useful question in order to think about treatments. And then the last question, how much does your family know about your priorities and wishes? So at the end of the conversation, summarize, it sounds like being at home is really important to you. Given your goals and priorities and what we know about your illness, I recommend for Beth and Jen, he said, I recommend that we talk with your family. We're going to do this together. And then affirming commitment. I think this is one of the most important things we can do. I'll do whatever we can to help you through this. And we really saw that in Beth's modeling. I'm going to help you talk with your husband and your son. So then you want to document in the medical record. Okay, so where do you go wrong on this? Well, not discussing prognosis or giving something that's really vague can actually increase anxiety. Or some people can tend to get off track, go off in a different direction. I would say that for today, really try to avoid having conversations about code status. I think we do that a lot, and it doesn't often get us to where we want to be. So resist the temptation to go there. Okay. So the purpose of prognostication is not to be right or wrong, but to just help people have a planning process in place. I think clinicians are really afraid of being wrong or losing trust or provoking anxiety, anger, or sadness. I think that you can say that you're uncertain about it, but most people really do want to know their prognosis, and patients realize that we're not perfect at it. The other thing is that having prognostic information can make people feel less anxious, and knowing what to expect can really make them feel more in control of their situation. And the other thing, I think we saw this beautifully today, is knowing their prognostic information doesn't make someone die sooner. So the order of the questions is important. We sort of talked about it. They're in a particular order. It might not feel right if you do these questions a lot. It might feel different to try to do this using a guide. If you feel that way, it's completely normal. And really, what you're trying to do is to get a sense of what these patients' values and goals are before talking about any sort of interventions or treatments. The other thing that I see people do is, sometimes people will say, I'm really afraid of dying, and then the clinician will jump in and say, well, you're not dying today. And actually, that tends to increase anxiety. A better response to that kind of thing is to say, tell me more about what you're worried about that. The other thing that the guide, and one of the things that's been really interesting in watching people use the guide, is it forces them to listen more than talk. So, usually in clinician-patient conversations, the clinician ends up talking like 70, 80, 90% of the time. And when they use this guide, it makes the ratio a little bit different. And then the last message is not to avoid addressing the patient's emotions, to just acknowledge them.